social protection actually features quite prominently within the UNAIDS outcome framework from 2009 through 2011. Just taking a look now at cash transfers, they've been used as a major form of social protection, and most popularly in Latin America, and I'll have a few slides on that a bit later. And while these cash transfers have been shown to be effective across multiple outcomes, like reducing poverty and inequality, most notably also in terms of improving various maternal and child health outcomes, immunization rates, education attendance, where there are these conditionalities tied to them. And this stuff is all fairly well understood. However, their application and relevance to HIV prevention is only now becoming explored through some rigorous empirical studies. And this particular presentation is trying to overview some of them that are out there. And I will have some conclusions and some statements that appear here, but just please note that they rest on maybe one or two studies, and more needs to be done in order to actually get to some sort of higher level of certainty about any of these conclusions here. So here's some of the key messages. The first is that there's some early evidence that shows that cash transfers, including conditional cash transfers, have some effectiveness for HIV prevention, but not in all cases. They have showed effectiveness across a range of conditionalities, so where that conditionality is tied to a structural condition like education attendance, or to biomedical services like DCT, or to proxy outcomes like remaining free of a curable STI. These are areas in which CCTs for HIV prevention have shown some impact. These impacts are often gendered. I'll talk a little bit about that some more. The impact pathways, though, particularly when we're thinking about these structural conditions, are still being investigated. And I don't think this is news to any of us on this RPC. I mean, it's one of the pillars of the RPC itself. And there's some questions, particularly for girls, which we'll discuss a little bit later, about whether or not it's the income or a schooling pathway for a CCT in a particular case in Malawi that's most important. And I think finally, it's important to realize that cash transfers are not a panacea by any stretch of the imagination. There's a range of programmatic, policy, and ethical issues that you have to think about before you even talk about doing a CCT, and even when a CCT is implemented. But there's a whole host of other social protection measures that need to be put into place that would be consistent with the CCTs and its objectives. So here's just the structure of the presentation. I'll have a few slides on backgrounds and talk about the conceptual framework and evidence around structural drivers of HIV, just to set the stage for the third section on empirical evidence, and then I'll have a brief snapshot on some of the issues and concerns facing policymakers. So again, just to situate cash transfers within a social protection framework, typically social protection is thought of in four different modalities, let's say, or there's four different stages to it, with the most basic being protective social protection. That's really providing a floor for people, keeping them, it's like a social safety net, and that's typically where cash transfers are situated. Then there's preventative social protection that deals with insurance, and then if you keep moving up the scale, you get into areas that have more recently been added to the social protection discourse about promotion and transformative elements that deal with equal rights and social justice legislation and those sorts of things. What's interesting, though, is when we're thinking about cash transfers is that clearly it's not just a social protection element about providing income to people and providing a basic social safety net to protect their income or protect their consumption. But with these conditionalities, what we're starting to see is also a behavioral incentive, and that's one of the things that we're probably equally interested within the HIV world. Next slide. Just to give a little bit of a lay of the land about how conditional cash transfers have developed over time. They were relatively rare about 14 years ago, so this is a map from 1997 where you can see that Mexico, Brazil, and Bangladesh were really the only three countries that had any sort of notable conditional cash transfer program in place, and those particular programs were actually quite small at the time. And they weren't national, as far as I'm aware, cash transfer programs at that point. But now they're a lot more widespread, so let's fast forward about 11 years, and you can see that almost all of Latin America and the Caribbean has some sort of cash transfer program in place, and that they've actually expanded to various other regions of the world. So you can see some in Asia Pacific and even some in Africa. I think the majority of this is probably in middle-income countries where you're seeing cash transfers really pop up and take hold. And even within the Brazilian and Mexico example, those particular cash transfer programs have become a lot larger, more integrated, and reaching a lot more people. We'll just skip on to the conceptual framework. Now, this is I'm trying to just paint a picture a little bit about a basic conceptual framework for factors of HIV risk. And as I said, I'm in the middle of preparing this paper for UNESCO on cash transfers. And so some of these ideas I'm just piloting with this presentation. So I'm really interested in people's feedback on what works, what doesn't work, and what's clear and not. Now, for everyone on this call, I'm sure that this seems like a very oversimplified representation of what we understand about structural factors versus proximal factors and how they link to HIV risk. We could probably draw a lot of arrows and put a lot more structural factors and proximal factors on the list, but I wanted to limit the scope to what I think is most relevant to what we know about cash transfers in HIV. And that really is around issues of poverty and inequality, gender, and education, which you see as structural factors on the left, and some issues on biomedical and behavioral services. And many of these pathways are both indirect and direct when we're thinking about how structural factors affect HIV risk. Some of them can act through promoting or inhibiting access to traditional biomedical and behavioral services, and some of them act quite directly. So when we were just having the discussion with Joyce about how poverty or inequality contribute to transactional sex and understanding of transactional sex, and how that contributes to HIV risk, that's more of a direct pathway that doesn't necessarily have anything to do with biomedical behavioral services. Just to drill down a little bit on the issue around economic inequalities and poverty, I think that this link is complicated, and it depends on the kind of scale that you're asking the question about how poverty and inequality relate to HIV risk. I mean, clearly, if you're asking the question globally, 90% of the infections are in poor countries, 2/3 of them are in sub-Saharan Africa, so there's clearly a link. But if you actually drill down to sub-Saharan Africa itself, that relationship really starts to break down. There's not really an association between poverty rates at a country level and HIV. When you actually look more of an individual level, if you just did a univariate analysis, broke groups of people in Africa into wealth quintiles, you actually still see higher prevalence rates typically among the more affluent than among the poor. But if you're looking again at a cross-country regression, which is this graph here, there's a lot clearer link between economic inequality and HIV prevalence. And this sort of suggestive evidence, I think, dovetails nicely with what Joyce is talking about with poverty, and as that relates to probably more likely inequality and how that falls along gender lines and communities. Next slide. This is just a brief schematic, pretty simplified, of how gender inequalities act through multiple direct and indirect pathways to influence HIV risk. So the top line looks at gender inequalities and how they affect violence against women via male and physical and social dominance and leading to unprotected sex. And at the bottom pathway is more along economic independence, also leading to increased unprotected sex. And I'm sure we could think about a lot more pathways here. This is just a simple version. Third, just thinking about education, which has typically been considered now a social vaccine against HIV. This hasn't always been the case. For the early stages of the epidemic, education was associated actually with higher levels of HIV risk, and in sub-Saharan Africa, the mechanisms for that were, or at least associations, were because of affluence, mobility, increased sexual risk behaviors. But now, education is considered protective, or it's associated with lower levels of HIV risk, and some studies attribute each additional year of education with a 7% reduction in HIV risk, and this is driven by safer and smaller sexual networks, which again alludes to some of the things coming out of Joyce's work about not necessarily being able to reduce transactional sex, but being able to help with partner selection and perhaps having safer and smaller networks. Also, education is believed to contribute to this HIV association, to delay sex and marriage, increase condom use. But again, these are, since they're not, you can't really, it's difficult to randomize education with any of these structural conditions. You can put a lot of caveats there. Let's look at some of the empirical evidence for cash transfers in HIV. This is a schematic that we just showed, adding proxies for HIV risk as a sixth category to look at how not conditional cash transfers, but cash transfers generally link up to HIV. So for the first one on poverty and inequality, these are typically impacts or outcomes of unconditional cash transfers and CCTs. So poverty can be an eligibility criteria, but also reduction in poverty tends to be an impact of these programs. Gender, women and girls can be targeted with cash transfer programs, but there also tends to be impacts that are gendered. 3, 4, 5, and 6 have all been conditionalities of conditional cash transfers in various studies, which I'll talk about next. So looking at just the relationship between cash transfers and poverty and inequality, there's clearly an impact. Cash transfers have been shown to have sizable reductions in national poverty, and this is across a variety of measures like poverty head count, but also in terms of the severity of poverty, which are measured by poverty gap and the squared poverty gap. And you can see a list of the programs in Latin America that have all been associated with reductions in poverty. And there's pretty strong evidence for this. Now, there's some evidence for reductions in national inequality, which is important if we think the link is more strong between inequality and HIV. This has been measured in terms of declines in Gini coefficients. And so there's one particular study, one or two, I can't remember exactly, that look at how the Oportunidades program and Bolsa Familia in Brazil have contributed to reductions in this Gini coefficient or to national levels of inequality. Now, having said all of this, none of these studies that are looking at the impacts of these programs on inequality or poverty actually look at downstream HIV impacts. I mean, it's just typically not within the scope of these particular studies, I think, for obvious reasons. Now, the gender component of cash transfers is interesting. Women versus men can be targets, as well as, even if they're not targets, the impacts can differ whether or not they're targeted to women or men. Traditionally, mothers, for instance, have been the target recipients of CCTs, especially those dealing with maternal and child health services, as well as for education. I think that there's a belief that's, I think, fairly well substantiated that mothers will spend the money on what it's meant to be spent on. And also, as we all know, women and girls are disproportionately at risk for HIV, especially at younger ages, and due partly to economic inequalities along gender lines. What we've seen out of some of the CCTs, which we'll talk about later, as they link directly to HIV or HIV services, is that women and their social networks can have positive spillover effects. So there's a particular study which we'll discuss later about conditional cash transfer leading to uptake of VCT, or is linked to getting your VCT results. Well, what's seen from this particular study is that women, but not men, actually benefited somewhat when their neighbors received a conditional cash transfer. So there's something about your neighbor actually going and getting their VCT that actually had a positive spillover effect for women, but not on men. And then also when women received the CCT, they tended to bring along their husbands with them. As the men received the CCT, they didn't tend to bring along their wives. So there's these interesting spillover effects that are very much gendered. And then on the last bullet point here is that when you're thinking about just the income effects of CCTs, there's some evidence to suggest that they actually have opposite effects whether or not men and women are receiving them, and that men will increase risky sex upon receiving an unconditional cash transfer, while women will decrease risky sex. So this is probably the mega study that prompted all of this discussion on CCTs and its role for HIV prevention. This is the Samba Study from Malawi that I made it hopefully a bit colorful and less wordy. But what this randomized control trial actually showed was that cash transfers have been shown to effectively reduce HIV risk. HIV risk was one of the things that was monitored. Now, this is not published. The HIV numbers are not published yet, but it will be forthcoming, I'm told, from the authors in a peer-reviewed publication. But from what we know so far is that in this particular study, adolescent girls in Zambia were randomized to receive a cash transfer of about, on average, $10 per month to the girl in the family, and the average age of the girls was I think something like 12 or 13 to age 22. And some of the cash transfer was conditional on school attendance. A different arm of the study was unconditional, so it looked at both of these things. Now, when you pulled both of those arms together, what you saw was a 60% decrease in HIV risk from about 3% in the control group to a 1.2% in the experimental groups, and then also 75% decrease in HSV2. Some of the school attendance impacts for the conditional arm were that girls were 3 to 4 times more likely to be in school. Some of the other impacts were delays in marriage and pregnancy, and then less sex, including transactional sex and younger partner selection. There's a question that hasn't been resolved yet about, well, what's the main mechanism in this study for showing the impact? Is it really just the income? Is it just the cash transfer? Is it just the schooling? Is it some combination of both? And if it's a combination of both, what's the relative contribution of these sorts of things? These sorts of things have been hypothesized, have been talked about in various presentations so far. Again, they haven't been fully unpacked in any sort of peer-reviewed publication. This is a table from a presentation that was given on this study at the Vienna AIDS conference. and it basically was meant to suggest or clearly show that there's definitely an income effect if you look at this highlighted section. That if you actually just isolate the girls who did not attend school regularly, who were then randomized to control or unconditional cash transfers, there was a marked decrease in their STI prevalence. Now, that doesn't necessarily mean that schooling doesn't have any effect. Schooling, of course, wasn't randomized, so there's lots of issues with compounding variables and actually understanding what the relative contribution is of school causally to this impact, to this contribution of HIV risk reduction. But if you look just horizontally across the control group, I mean, where you can see that there's a 14.7% STI prevalence in girls who did not attend school, and then a 2.8% prevalence in girls who did attend school, there seems to be some sort of suggestion there that schooling does have an impact, but again, it's something that the authors have yet to really unpack. If we look at CCTs for biomedical services, there's a case study, again, in Malawi, a community randomized control trial that showed that there was definitely some an impact on VCT uptake. So there was a cash transfer given to men and women that averaged about $1, and it was conditional on retrieving their VCT results. Those who received the cash transfer were twice as likely to get those VCT results, and each dollar was associated with a 9% increase in retrieving those VCT results. Now, if we look at actually CCTs that have been tied to HIV status, there's only one study that I'm aware of, and it's just a working paper, and it didn't show any sort of effect. So that this particular study provided a cash transfer, again in Malawi, of $0 for $16, and it was, I'm sorry, the conditionality was not retrieving VCT results. That's an error. I was copying from the previous page, but the conditionality was actually staying free of HIV after 1 year. But the results were there weren't any results to speak of. That there was no effect on HIV status or reported sexual behavior. But what they did find was that after the final incentive was paid, and it wasn't linked to any conditionality anymore, that men actually increased their risky sex while women decreased their risky sex. So there was a variety of issues that were discussed in this paper. Clearly there's issues around stigma, about tying conditionality to HIV status, which has to be worked through. But there's also issues of program design and whether or not the frequency of the incentive was sufficient enough to actually yield a result, because there was a 1-year time lag between the incentive and the conditionality, versus some other studies make that cash payment much more frequent. And then again, there's issues around perverse incentives and some other things. And then finally, there's one study that looked at a proxy for HIV risk, making that the conditionality, remaining free of a curable STI, for a number of reasons. One is to avoid the stigma issue. Instead of making it tied to HIV status, let's tie it to something that's curable, that's less stigmatizing, but rooted in a behavior that would also be associated with HIV. The bonus of making it tied to a curable STI as well is that you can include people who are HIV positive as part of a positive prevention strategy and not excluding people who are HIV positive. So again, the cash transfer design was $0, $10, or $20 every 4 months. So that was $30 or $60 a year. It was remaining free of a set of 6 curable STIs like gonorrhea, chlamydia, etc. HIV status was not considered at all. People living with HIV were included. It wasn't part of the eligibility criteria. So the results were interesting, and it speaks to how important the level of cash transfers are. The lowest level of cash transfer, which is $10 every 4 months or $30 every year, had no effect on STI rates. But those who were receiving the $20 every 4 months had a 25% reduction in STIs. So the conclusions, the takeaways from this particular study, and again, it's just one study, was that CCTs tied to HIV proxies can work, the value of the cash transfers matter, and that using curable STIs can be a non-stigmatizing proxy. So this is just to wrap up. I kind of ran out of time putting this presentation together, and there's a whole host of issues, ethical issues and concerns around program design for cash transfers generally, as well as some that are uniquely important for cash transfers for HIV. I'm just listing them here. Maybe I'll talk over them a little bit, but there's a lot here that has to be unpacked, and there's a lot of debate and discourse on this already. There's issues around program design just generally about how you target people and whether you're targeting them well. This is an issue with HIV in particular about whether or not you're going to be stigmatizing people. Payment size, timing, and frequency are really matter. Whether or not you're going to see an effect of a conditionality, for instance. How you select your conditionality really matters. You have to be wary of perverse incentives, so having unintended consequences, which speaks to needing to be able to monitor and plan well. CCTs, again, are complements and not substitutes, particularly if they're linked to services that you're going to get at a health center, for instance. It doesn't do a lot of good to have a conditional cash transfer. The service doesn't exist in the first place. There's issues around costs and M&E requirements, particularly for monitoring conditionalities and results. Cost effectiveness, people have talked about long-term dependency. Now, for HIV in particular, where you get into some of the I think, probably more heavy concerns that are particularly poignant for HIV, are these human rights issues, which I've already talked about. Can you really tie CCT to HIV status? How horribly stigmatizing is that going to be? A lot of people basically come down on the side of, that's probably not the right way to go. Hence, you see this study on HIV proxies like curable STIs. There's discussions around coercion, and then there's a last dialogue going on, part of the UN system, about HIV-sensitive versus HIV-exclusive social protection and cash transfers, which is a little bit I've shown on the next page, which is an attempt to try to integrate HIV concerns within existing social protection and cash transfer mechanisms and not creating parallel programs, both for issues of stigma, but also for issues perhaps of cost and feasibility and reach, that it may not be the case that in a particularly a lower prevalence environment, that you're going to create a separate program, a parallel program, just to target people who are affected by HIV, who are at risk of HIV. And this goes for particular groups, like marginalized groups, like men who have sex with men, transgendered groups, that even if they don't have HIV at the moment, creating programs that target them can be quite stigmatizing in and of itself and be counterproductive. So that was a mouthful, which took quite a bit of time. That's the end of my presentation. I'll just stop there and open it up for any reflections, feedback, questions, comments.
Thanks, Brian. That was really interesting. I think I'm particularly interested in your last slide because I don't know if all the partners on the Pathways grant are aware, but we're in the process of doing an RCT of a conditional cash transfer in South Africa with partners at UNC and then with other partners at the university, the Agincourt Health and Population Unit. And I think it's interesting because the idea of an integrated cash transfer program to address HIV is something that we really need to emphasize, because I know it's one of the big criticisms that we get of our project. And I'd be interested if anyone has ideas about how you might do that for different populations. The study that we're doing is targeting adolescent girls, and it's relatively easy to think about an integrated cash transfer program for young women, because we know in South Africa that there's a strong association between school attendance and HIV. And so what our study is trying to do is pay a cash transfer conditional on school attendance, but with an aim to reduce HIV incidence. And so I'm just curious about if anyone has thoughts about how it might be possible to do an integrated approach for other populations. Our idea, if our study is effective, is that we would make policy recommendations around the child support grant to introduce hard conditionalities to the child support grant, which is already in place. It's an existing social protection mechanism. We wouldn't be replicating payouts to poorer families. So I think it's easy for our target population, but not so easy for other populations.
I'll try to reply and hopefully provide some sort of helpful response. The first thing I'll say is that I think a lot of people are still working through these issues about what HIV-specific versus HIV-sensitive are, so there aren't any sort of hard and fast rules or conclusions right now. The other thing I'll say is that I think there's probably a difference between what you're doing in a study versus what you would want to do as a policymaker and actually scale something up. I would imagine for a study that these sorts of HIV-specific versus HIV-sensitive are probably not the primary concerns. So I think they should be on the radar. I think studies are particularly interested in just showing some sort of efficacy and answering the very quite specific questions that they have. Now, if the study is meant to look at how you do integration, then I think these particular issues become more important. And the third thing I'll say is just that in some of the conversations that I've been in with various agencies of the UN, different country governments, particularly in Asia, where they had a consultation in Cambodia just recently on HIV-sensitive social protection, I think a lot of different countries recognize this, at least in the Asia region, as particularly important. They were also wondering, how you actually did this. In some countries like India said, well, look, sometimes we have HIV-specific programs for very good reasons, and sometimes we have HIV-sensitive programs, and these are the programs that we think need to be made more HIV-sensitive. And some of the things I'm thinking of, for instance, are like some pension reforms that they've done in various states in India, where it was they had existing pension schemes, different eligibility criteria for them, and it was almost like adding different categories of people to those. And one of them was women who were widowed due to AIDS, and that was just a separate category that they added within a particular pension system. And, rather than creating something entirely new, they wanted to go through the existing channels, and it was really about adding different categories of people. But again, in thinking about the stigma issues around HIV, figuring out what categories those are is particularly important. Probably for adolescent girls, it's not such a big issue, but when we're talking about people who are HIV positive, intersex men, sex workers, let's say, injecting drug users or whatnot, those issues become particularly important, and people are trying to think of different categories as proxies to capture those groups without actually making that an eligibility thing. Raise your hand if you're a drug user. That sort of thing isn't probably going to fly. I hope that was helpful, but if I come across other things or we want to have a follow-up discussion, I think that would be, that's absolutely okay on my end.
Okay, so we have Catherine and Justin. And Catherine, did you want to reply to this same question, or do you have a new question?
Yeah, I think it's on the same issue, actually.
Okay, we'll go ahead and then we'll do Justin.
Okay, I'll make it quick. I was just thinking about, because the relationship between poverty or economic vulnerability and HIV risk is so complicated, and I think we're still grappling with how to understand it. It just makes me think about the real importance of not making HIV research studies carry so much of the weight of some of these structural approaches that we want to try. So having, HIV outcomes as being, the main outcomes, or it just seems to me that integrating that as one among many or several outcomes that one looks at is probably a more effective way in general of us exploring the structural barriers and making cases that are going to be appealing. I just worry about the HIV research field carrying too much of the burden of the gender equality kind of mission in some cases, and us not being able to do it well enough that we're pushing any agenda forward.
I think that's
I agree.
Yeah. I was just going to say, I think that's a good point, and one of the things that has emerged already in some of the cross-conversations in the RPC is the need to really make sure that while, DIPID's primary interest is HIV, and we all share that interest, that we should make sure that we're collecting outcome information to the extent possible on, some of the adolescent health or maternal and child health or some of these other outcomes which are of broader interest, and that we're not just thinking about, making the case of structural drivers to the HIV community, but to a lot of the other communities that are out there. Justin, did you want to ask a question?
Yeah, I did. I just had a thought actually about that last comment, which I agree with, which is just that I was at a conference, the conference in Durban last month, I think, or a month and a half ago on the social sciences of HIV, and there was a good presentation about basically a social development program which may have had impacts on HIV risk, and they kind of asked the question of, is this a structural HIV intervention? And my view was, no, it's not. It's a structural intervention. It's a social development intervention with important HIV aspects which we could come in and study. But as Kathy said, we shouldn't kind of assume all of these things are the remit and the responsibility of HIV people, but we should look for these opportunities when integrated or broader social development, social change processes are going on to actually have some kind of we can do research on it, we can have inputs in it and the like. So having that distinction is important, I would say. But that's just a comment. Sorry, back to Brian, though, in your presentation. Thank you for that. I had two things. I had a comment and a question. I'll try and make them quick. I know we're short on time. The comment was just on your conceptual framework, and I know you mentioned that you know it's a simplification in many ways. I would just be wary of kind of the assumptions we make sometimes and how things that we value often come across in it. You only had a red line going from poverty to HIV risk, which implies that poverty is always and in every case increasing HIV risk. And what we don't like saying that poverty can be positive in some ways, but we do know of cases where poverty reduces risk. When you're socially isolated, you don't have as many partners, you can't get out of your home. It's not a good thing to be in that situation, but it reduces risk. So epidemiologically, we have to be aware of that. Similarly, wealth, and you mentioned yourself in many cases, we see wealth and wealthier individuals with higher HIV risk. So the transition from poverty to wealth can have risks in terms of a changing risk profile. And that kind of leads me into my second question, which is about, you showed that the multiple pathways that you can get from an underlying structural factor like gender inequality to an HIV risk, which fundamentally says that there are different mechanisms at play in different contexts. The impact that poverty has and the impact that gender inequality has will be context determined in terms of how that plays out in risk. And so my question, and this is maybe a question that our RPC is going to have to engage with, but I'm wondering your view on it, is how much investigation do you think we need in advance before we start doing cash transfer programs in terms of which causal pathway is actually functioning? Kathy mentioned South Africa, they're doing it because they have a good understanding that it's being out of school, and so they make that the condition. But I worry sometimes we see interventions which kind of say, let's do poverty reduction, let's do microcredit, let's do cash transfers, without actually understanding what your causal pathway is, which then risks targeting something that's not there or potentially getting a negative outcome, as you saw mentioned in that Malawi case where after it was paid, some men started having more risky sex. So how much background research do we have to do? How much do we have to understand about that causal mechanism and that process first before we can go ahead and do these sorts of interventions?
Wow, that's a big question. Let me respond to the first point first. Absolutely well taken, and it is a simplified framework. When I was playing with it yesterday, I actually had poverty and inequality separate and was trying to get at some of the nuance. And I just said, you know what, this isn't going to work. So I just put poverty/inequality and started drawing some lines. And I was like, I'll just talk over it. But it is a complicated story, this relationship between poverty and inequality and HIV risk, and one that needs sort of, you can't explain it just a diagram, but needs sort of talking over or some more writing. Now, on the second one about how much do we actually need to understand before we start doing cash transfer programs, understanding them, in some ways I think transfer programs can answer the question both on whether or not there's what the pathway is, and whether or not how much a structural driver matters, and whether or not this particular mechanism matters as well. Because if you're thinking about like the conditional cash transfer program in Samba, the way that they designed it was basically a backdoor way, I think, of one could conceptualize it as randomizing poverty reduction by actually providing some people with conditional cash transfers, some with unconditional cash transfers, and some with nothing. I mean, clearly, there's a conditionality that has an incentive associated with it that you have to parse out, but then that underlying cash is really getting at a randomization of, some might say a reduction in poverty and or inequality, one of those two or both. And so it may be that those cash transfer programs themselves help illuminate some mechanisms and some relative contributions of these structural drivers. I mean, otherwise, I don't really know. I mean, I'm not really an epidemiologist. I don't do epidemiology day in and day out. I haven't done it in a really long time. But I don't really know if really unpacking poverty and inequality through these cross-country regressions and things, I don't know how much more you're going to get from that sort of approach. And I don't really know how much more you can really unpack something that you really fundamentally can't randomize. I don't know if we're sort of at the methodological limit of that. I don't know if that's a particularly unsatisfying answer, but that's sort of where I'm at.
Just a quick response is that I didn't actually mean unpacking it quantitatively through national survey data. I think you're right. I mean, I've published on this on the wealth and poverty relationships, and other people in our consortia I now have. I meant more the qualitative unpacking of the mechanism. So doing the kind of work like the first presentation talked about so much, to try and understand, what's driving risk behavior in a particular way, how people's poverty or their wealth or their education or their being out of education is therefore being linked to risk, and then by that kind of much more qualitative understanding of the causal pathway, then designing the intervention is what I meant. Sorry if I was unclear on that.
I mean, that's a good. I think it's an idea, and I thought Joyce's qualitative research, for instance, I thought was great, and it was very enriching, and I think is probably really important for designing policy and designing and being able to test these particular mechanisms. My preference would be to be moving both arms at once. Continuing through the qualitative research and really unpacking what is this interaction between gender norms and cultural understandings of transactional sex and poverty and inequality, and how that all links together, and versus let's take stabs at some limited trials that look at some of these things and give us some sort of way forward at the same time. I don't know if we need, I hesitate to choose one over the other.
Okay, I think that unfortunately we've gone beyond our time, so I think I'm going to have us close now, but recognize that this is the beginning of a much longer conversation, and if indeed we decide to try to take on board designing, a multifaceted intervention for adolescents, the folks who will probably have a smaller working group of those people who want to really talk through these issues at length and really try to suss out some of the issues we've just been able to kind of touch on today.